Welcome to the Ortho Joe Show, a joint production of the Journal of Bone and Joint Surgery and Orthoevidence. In our world, orthopedic research is king, and current topics from our respective publications are analyzed weekly. Here is Mohit Bhandari from Orthoevidence and Mark Swinkowski from the Journal of Bone and Joint Surgery.
Well, Mark, welcome to another morning episode of Ortho Joe. I have my trusty cup. I hope you have yours.
I absolutely do.
I think
and it's last night. My wife and I we went to the Jackson Browne James Taylor concert. So
oh wow,
we didn't get much sleep, but it was a fantastic show. So
isn't it nice? But isn't it amazing now to be out and seeing people? I was at the Toronto Symphony Orchestra with one of our residents. Yes, ortho residents do listen to the symphony, folks. Just letting you know. He dragged me there, and it was actually quite nice to see people. It was nice.
Yeah,
very nice.
Great.
Yeah. So today we have another, I think, a friend to both of us, a colleague to both of us. I've known this individual, Dr. Gerard Slobogean, who's an associate professor, a director of clinical research at the University of Maryland School of Medicine. His interest is, and he's fellowship trained in all these areas, complex trauma and upper extremity. Gerard, welcome to the Ortho Joe podcast. And just to note that you will get one of these amazing. Wow.
Sorry, I already have it.
How is that possible? How is that possible? I'm impressed that you're a true fan. You're a true fan. You've got this. It's awesome.
I definitely am a true fan. And by far the highlight of every podcast is this opening that you guys have, and you guys run a top-notch shop, and you guys already sent me out the cup, so I appreciate it.
Well, Gerard, I'd say, but you happen to have the signature cup. Would you have the signature cup? Because I can sign one for you, and so can Mark. I mean, those things may go for $2 somewhere.
Yeah. $1.50 anyway, maybe.
$1.50, fair enough. So if I could just maybe just start up with an open-ended question to you. Can you explain to, I guess, our audience and our surgical community, what right now is interesting you in the area of open fractures? What's kind of on your mind, and what are you looking at?
Yeah, thanks, Mo. That's a very broad question, because I think, like all of us, we are still perplexed by why we can't get better results in open fractures, and the fracture-related infections from these injuries and the increased non-unions and stuff haven't really been solved. So I'm interested in anything that can help with that. And, I think there's a handful of areas that have some promise that we can kind of discuss. But I don't know that there is a smoking gun right now. These are bad injuries. And for those patients that are unfortunate to have, this happen to them, a good portion of them are going to have a complication.
Isn't it pretty similar to what we see in a lot of other areas where it's no surprise to you that we've spent decades trying to sort out hip fractures, distal radius fractures, proximal humerus fractures. You can go on and on and on. But there is nothing that gives you that same sense of urgency as trying to understand the complexity of an open fracture. Do you think the solutions that come are going to be direct operative solutions, or are they going to be part of that non-operative, perioperative area?
I suspect it's probably a combination of the two. At times I've been very depressed that, maybe anything we do in the OR doesn't seem to matter, and it's more of the patient and the perioperative care and stuff. But, flow has shown that, simple intervention in the OR might actually have a difference in terms of soap being harmful. We know that, perhaps even putting topical antibiotics in wounds may have a difference. So I do remain hopeful that there are some things that we will learn and do at the time of surgery that will make big differences. And I think, looking in the last 10 years, and particularly in the last 5 years, this whole orthoplastics concept that is being, I think, more formally described, I think is probably one of those sort of surgical advances in terms of just better understanding how to care for the soft tissues at the same time as the bony injury.
Yeah.
So you mentioned antibiotics in terms of topical form, but I think most people worldwide would agree that if possible, we should be using IV antibiotics. And as a matter of course, whenever we do one of these Ortho Joe things, I always do a quick search on jbjust.org and look at what we've published recently. And Mo, is your group at MAC published in JBJS Reviews a really extensive review of antibiotic therapy, 223 publications plus a very large number of surveys internationally, and that the broad conclusions were most publications and experts think that you should cover for gram positive and gram negative for 2 to 3 days. And so I guess I just bring that up to ask both of you, is there any recent publications that clarify that even more, or are there studies on the way that are going to clarify the duration and type of coverage for IV antibiotics?
Yeah, I mean, I think the answer is yes to both of those questions. I think your first comment, I completely agree with. The topical antibiotics that I'm referring to are in addition to the systemic, IV antibiotics, which I think is pretty well established now. The other comments, I think, in terms of duration, we had our group with Mo's group had used the flow data to look at sort of duration of antibiotics using the OTA OFC sort of classification in terms of the contamination. And we found that, for severely contaminated wounds, extending the antibiotic duration even beyond 72 hours seemed to be protective against reoperation. So I think we're slowly making some progress. I think there's been, the antibiotic stewardship sort of movement pushes back on us not thinking and not being critical and just leaving antibiotics on indefinitely. But I do think there are patients that have severely contaminated wounds that would probably benefit from a more thoughtful approach. And in those cases, perhaps extending antibiotics. So I think there is some evidence that's come out in the last 3 years. I think that publication came out that would support that. And then in terms of your second question about, are there other studies coming out? I know the Metric Group and Mike Bossy, have been looking at trying to continue to tailor the antibiotic, both duration and choice of antibiotics to improve the outcomes, both based on local patterns and things like that. It's just, I don't think it's a one size fits all, and that's really hard to study then in a clinical trial.
Go ahead, Mark.
Well, just the whole issue of one size doesn't fit all just brings up the recollection of the issues with classification of open fractures. And I go back to a classic study that Bob Brumbach did at the OTA meeting, just showed a bunch of videos of people debriding wounds and looked at the inter and intra-rater reliability of the classification, and the kappa statistic was very poor. So that's really one of the major issues that remains today, is that in one center a 3A is a type 2, and in another center a 3A is a 3B, and it depends on how available is a highly skilled microvascular surgeon, et cetera, et cetera. And I think that's a real area that's going to be a struggle forever in this whole area. I don't know if you two agree with that.
Oh, for sure. Like when we did, simple observational studies where we said, okay, what factors predict, let's say, reoperation in a tibial shaft fracture, trying to decide whether it's a type 1, type 2, type 3, A, B, or C, it was, there was all kinds of variability. And what we found actually was open, period, any open fracture, the fact that there's, break in the skin conferred some degree of additional complication and risk. And that was something we knew, okay, someone can reliably make an assessment that there's, an open fracture. They may not agree necessarily on the type specifically. Now, clearly there's going to be gradients of challenge as you go up, but simply having an open fracture completely changes the trajectory for that individual patient. Which gets you back then to the idea of, you've got this issue of, Gerard, and this is the point, around you've got an issue of, okay, how quickly do you irrigate? What do you irrigate with? When you debride, how much do you do? How quickly do you get them to the OR? What is your surgical technique? What type of implant do you use? When do you, wound closure? And then all the quote, biological enhancement therapies. There's all these incremental steps. And when you think about a program of trying to sort this out, is it simply just dealing with one step at a time? Do you prioritize one over the other? Do you pick the simplest? Or do you say, let's tap into something that we think might actually be really important, but it's unlikely to be done if we don't do it collaboratively? And I speak to one issue, which is timing. But, I'm curious what your take on is.
Yeah, lots to discuss there.
Yeah.
I mean, maybe I'll backtrack a few comments. Dr. Swintowski, you mentioned sort of going through the JBJS and seeing what was published recently. Yeah, I think it's interesting, right? There hasn't been a lot published that is therapeutic. There's some review articles, there's some systematic reviews, things like that, but we just really haven't produced really strong data in a long time. And so that in itself identifies a challenge and a problem. And then Mo, to your point, how do you incrementally pick off these things? I think you and I share a similar philosophy. Thankfully, you trained me, so hopefully we do share some similar philosophies. But I'm a very big fan of simple interventions that can be easily implemented, widely disseminated, and hopefully aren't too costly. So that has been my bigger interest in terms of how to pick off some of those issues. When it comes to, I think Mo, again, you really pioneered the large RCT, and even some of the factorial stuff I think is great innovation. And I would like us to continue.
So can you explain the word factorial to some, because I think some might not understand what that means.
Sure. Yeah. So, as you mentioned, the one trial studying one thing at a time is very time costly, financial costly, and it really only allows us to answer a few things at a per trial. And so a factorial design is an ability or a study design that allows you to test more than one intervention with the underlying assumption that the two don't interact together. And so that by doing so, you can put the two different interventions in the same trial and essentially analyze them almost like two separate trials within one. So it's a lot more efficient. It only increases the sample size sort of marginally, and doesn't require two separate trials. So I think that was a huge innovation. That's what was done in Flow. But still, now we're only testing two interventions, and so if we are either able to get to more efficient large clinical trials or get better at some of the causal observational study designs, I think we may be able to sort of more rapidly test things. But, causal inference has so many problems at its root. It still may be the best we can do, but it has a lot of challenges. And so the trial, I think, still remains the gold standard. Sorry, go ahead, Mo.
No, I was going to say that, to that point, the Lancet Commission on Global Surgery had this statement, pretty bold one, right? Saying, among some of the bellwether procedures globally that can improve life, the managed rapid treatment of open fractures is one of them. And in fact, they make the argument that, they would like to see a world in which open injuries around the world get initial treatment, however we call initial treatment, within 2 hours. Somehow, this group has determined that timing does indeed matter, where if you look at the series of observational studies, prognostic studies, you wouldn't necessarily get that same impression. I mean, there's quite a bit of variability there, Gerard. And I wonder if that is an area for someday a target. The same way, you've seen hip fractures being, in the same scrutiny of can earlier care lead to better outcomes?
Yeah, I think the challenge there is, you get away with using the word care or treatment, but the investigator has to be very specific about which part of that care or treatment they want to investigate. And that's challenging, and you look at the in-training exams that as far as I know, the correct answer still is quality of debridement, and then maybe timing of antibiotics. And I think as the literature is perhaps starting to show, both of those may be correct, depending on which clinical scenario you're talking about. If there's tons and tons of dead bone and contamination or whatever, the timing of debridement may matter. But if it's just sort of your average 3A, 3B, whatever that means, I suspect timing is less important as long as it's done within a reasonable time period. And lowering the bacterial burden through antibiotics is probably more important.
Well, I will just say the mere fact that you work and you call a 3B an average 3B tells you work at shock trauma. I can tell you right now, there's not too many people in the community walking, just an average 3B. So, just an observation, Gerard, just an observation.
Yeah, Gerard, as you mentioned, there hasn't really been a lot of new primary evidence published. And there again, you're correct in my review. So there another really strong meta-analysis done by a very large global open fracture collaboration was published in the journal in 2020, 84 studies and a meta-analysis, and identified that based on that high quality literature review, again, based at McMaster, the critical threshold seems to be 12 hours. So as best as we can from the literature today, that seems to be the reasonable time for a higher grade type 3 open fracture. Anything different that you've seen on that?
No, and I've seen that paper as well, and it's the usual, right? I am just so suspicious of residual confounding. I clinically believe that result, but I just know that, for example, at my institution, both for time to debridement and time to flap coverage, we're going to get all of our patients debrided in less than 12 hours. We're going to get all of our flaps done within 72 hours or covered, certainly within 24, 72 hours of definitive fixation, except the patients that are so sick that can't make it to the OR. And we see that, I don't want to say frequently, but regularly. And so I just know that in our institution, there is massive confounding that I'll never be able to get rid of, because the patients that aren't getting to the OR in those sorts of timeframes are extremely sick.
Yeah. And when you look at sort of in the more austere environments where you don't have access, right? I mean, transport to definitive care is a big problem. That's where I think some of the work you've been doing, and maybe we'll ask you to share a little bit about that, which is the type of irrigation, getting early antibiotics put into that patient right at the scene. Those kind of things, I think, will give you that extra window of opportunity where potential, a definitive care can be delayed somewhat. I think it's the absence of any care that certainly is the real challenge. And, in one of these places, we've got to find some of these, quote, as you say, frugal interventions that can help. I wonder if you could speak a little bit to your ongoing program of research, the PREP-IT program, just for those who may not be aware. I think most probably interested in the area know about it, but for those who haven't, it might be interesting to hear about what you're up to.
Sure. So PREP-IT, as you describe it, is a program. It's two large sister trials led by Sheila Sprague and myself and you. if you recall, Mo, you've actually provided quite a bit of seminal expertise and guidance for us. But this trial is coordinated at McMaster and a collaborative effort across North America and Spain. And what it is two sister trials comparing the common antiseptics of chlorhexidine and iodine-based or iodophores. And it's both in open fractures and closed fractures. It also includes the aqueous-based solutions and the alcohol-based solutions. And when you look at sort of the Cochrane review on this topic, it really did call for that sort of factorial analysis, and we even considered doing a factorial design of the alcohol-based ones and the non-alcohol-based ones, but decided to go for separate trials. So we've exceeded 10,000 patients enrolled. The enrollment is wrapping up in under 4 weeks, and we're quite happy with it. The primary outcome obviously is surgical site infection, which we've been able to maintain well over 90% follow-up. And, the McMaster group and Sheila Sprague and all of our collaborators have really just done a phenomenal job on that trial. And so, we're going to answer that primary question, right? Does iodine or chlorhexidine make a difference in surgical site infections and non-union reoperations? But as you point out, this will provide a lot of other opportunities to look at, time to debridement, topical antibiotics, other co-interventions that we know may have a benefit. And we'll see. 10,000 patients is a lot of patients. Flow is a huge number of patients. And, this is going to be a little bit bigger that we can combine even with flow data and just continue to get better and better data sources to try and answer some of these difficult questions.
Can I just ask, how are you dealing with the classification question in that trial? Are you taking pictures, or how are you dealing with it?
Yeah, so that's a good question. So first of all, the misclassification, if you will, right? The potential for misclassification, I think, gets knocked out, right? It's a randomized trial, so I expect the misclassification to be equally balanced, in equal amount of noise on both sides. We are using the classification to stratify for one of our subgroup analyses. But as far as I recall, it's basically ones and twos versus, threes, right? So we're using it sort of at the dichotomous level, and I'm hopeful that level of classification can give us a good enough sort of trustworthy classification. But again, that is just a subgroup, and I'm hopeful that the noise will be equal on both sides of that.
Can I? Oh, I don't know. I just have and Mark, I have a general broad question that's unrelated to open fractures. But if you have an open fracture question, I'm happy for you to jump in, because mine's a bit more of a tangent.
Okay, I'll let you go last. But
okay.
My last question for Gerard is: so there's likely people listening to this podcast or viewing this video that are in community practice. So if you could just summarize, with your extensive knowledge of what we know to this date, how would a surgeon best manage, let's just say it's clear type 3B open fracture that shows up in a community hospital? What are the essential evidence-based recommendations as we know them today? Let's say a tibia type 3B middle third fracture. How should that be managed today?
Yeah. Okay. I'll see if I can go through it as sequentially as possible, because I do think there are a lot of decisions to be made. So, right from the time of the patient's presentation, I do think that antibiotics should be started as early as possible. And I think that basically should just be a cephalosporin, ANSEF. If there's any concerns for contamination, and particularly if it's an isolated type 3 injury, I think adding gentamicin or aminoglycoside is very reasonable, and I probably would do that if there's any contamination. You might want to be a little cautious if you have a multi-trauma patient that's under resuscitated, to minimize your acute kidney injury risk. But if it's sort of isolated injury, well resuscitated, and contamination, I would add aminoglycoside. In terms of the ED wound management, I personally prefer sort of betadine soaked dressing. I don't know that there's strong evidence for that, and then splint. In terms of the time to debridement, I think that you should, debride these fractures as soon as possible. However, I still am a fan of the balance between midnight, in middle of the night surgery, where you have assistants that may not be facile and all the things that you need, and you may be more prone to cutting corners, to be honest, right? We're human. Mm-hmm. And so I think debridement within 12 hours is very reasonable. The other two parts that I think are worth talking about sort of intraoperatively are, well, how much of a debridement is required, particularly because a lot of people still believe the quality of the debridement is the number one factor. I am a little less skeptical, or I'm a little more skeptical about that. I do not favor massive excisional tumor style debridements. You have to get gross contamination out. And I think that this is an area where we may have some innovation. Leah Gaetan at Dartmouth is doing a lot of laser angiography, SPY type stuff to try and assess what may be viable. And that may be an objective way for us to better understand what is viable tissue and what's not. So look for her research and other similar research like that. But I think you need to do an appropriate debridement. You shouldn't be afraid of doing a debridement that creates too large of a hole, because I think most of these injuries require good, robust soft tissue coverage, and hopefully your flappist can help you in that regard. And then the other part that I think is probably important, the data is getting better, but still not perfect on this, is the time to flap coverage in relation. I think it's in relation to the definitive fixation. I think it's less important about the time from injury, but I don't think you should definitively fix something and then leave your hardware sitting in the breeze for days. So, we try and plan that at least within 24 hours, if not on the same day. And then the last part is just the duration of antibiotics afterwards. Certainly for most 3Bs, 24 hours of antibiotics, I think, are fine. Again, as the contamination level goes up, I would consider 72 hours. And as it really goes up, I would consider even like 5 days or even 7 days in the very rare occasions when you're really dealing with bad contamination.
That was outstanding. Thanks very much. Now, Mo, you're up.
Sure. And the truth is, even after all of that meticulous care, Gerard, we still haven't solved the issue of the complex open fracture, which I think we started off with. And I think we're going to solve these fractures when we have surgeon scientists like yourself engaging and inspiring sort of the next generation of surgeon scientists. Can you speak a little bit about just what it takes from your perspective, in having pursued this area? And, if you're making your pitch to others who are on the fence about, maybe a senior resident, could be a fellow thinking, do I go in this direction? Do I get additional advanced training? What's your pitch to that person about the, sort of the satisfying aspects of this thing? But it's not easy.
Yeah, I actually didn't expect that question, but thanks for this opportunity, because I do have strong feelings about it, and I think it's really important. So I'm truly humbled to be on this podcast with you guys. And Mo, I know when you were getting started, you reached out to Marc for mentorship, and,
right.
and I reached out to you for mentorship. And I think it's only possible for us to do good things when you're already standing on the shoulders of another giant. And so I just, I truly implore any young surgeons that are interested in doing really high quality research. You can't do it on your own. I can't do it on my own. Mo couldn't do it on his own. You can't do it on your own. So you got to seek good mentors that have a track record of doing good quality research. And I think at the very least, the mentorship and sort of trying to plug in with people that have done this before is most important. After that, I think, getting advanced training is also extremely important. We have the OTA and all these other scientific meetings that we do. And there's a large portion of that that's research related, yet most people spend very little time learning research or even sort of continuing education in research. Yet we have journal clubs, we go to AO courses and all these other things to continue to keep our surgical skills up. So if you want to be a good researcher, you have to continue to keep your research skills up. So I think that's really important. And then, I think if you look at the big picture of where orthopedics is in terms of federal funding, NIH, and things like that, for those of you that don't know the US system, we're in an institute called NIAMS, which is, musculoskeletal based, but it's also dermatology and rheumatology and things like that. And we really don't have the resources that these other disciplines do, because and we have our burden is way higher than theirs, and so I think we need to get better at organizing as a group in terms of getting these resources available, looking for centers and things like that can provide more training, more consortiums, more opportunities, and McMaster has been a huge leader in that. And again, Mo, I really appreciate all the mentorship you've given me. Metric has been trying to sort of grow a robust consortium, and there's a lot of other consortiums that are growing from the younger generation as well. And I think that we just need to continue to find ways to support that through legitimate funding. And I know Dr. Swintowski and the JBGS has been working with other centers. I recently heard about the collaboration with the Total Joint Core Center and stuff like that. And so I think other disciplines are making it, even in orthopedics. And for ortho trauma, we have really big, unique challenges. The injuries aren't the same, they're unpredictable, et cetera. And so we have to get better at providing the best available evidence. And we may not always be able to do it in a nice, clean RCT. And so we have to learn how to do that.
Well, I just want to thank you, Gerard, for an outstanding interview for our Ortho Joe, and I'm convinced that the world of a patient with open fracture is going to be a much better place in the future, thanks to your work and your energy, and to Mo's for bringing you along and then turning you loose with this problem. So thanks, and we hope that you'll enjoy your cup. It's very useful, and particularly on a day when you haven't had much sleep. So thanks very much, and all the best.
All right. Thanks again. Thanks, Gerard. Thanks, everyone. Thanks, Mark.
Yeah.